Hello, and thank you for joining today's virtual education program with Cancer Support Community Los Angeles. I'm Larissa Montalvo, and I am the program manager here at CSCLA. And I welcome you to this week's webinar titled, Frankly Speaking About Cancer, Lung Cancer. Today, we will be joined by Dr. Ani Balmanoukian, Director of the Lung Cancer Clinical Program at the Angeles Clinic and Research Institute, to learn more about the types of lung cancer, potential treatment and side effects, and clinical trials. But before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you'd like to learn more about our services or watch our past webinars, please visit our website at www.cancersupportla.org. So without further ado, I would like to welcome today's speaker. Dr. Ani Balmanoukian leads the lung cancer clinical program at the Angeles Clinic and Research Institute. Her clinical areas of research include novel targeted agents, immunotherapeutics, and early drug development. She has led the charge in immuno-oncology for lung cancers. Dr. Balmanoukian earned her medical degree from New York Medical College School of Medicine and completed a residency in internal medicine and a fellowship in hematology and medical oncology at Johns Hopkins Hospital. She's board certified in internal medicine, hematology, and medical oncology. Welcome, Dr. Balmanoukian, and thank you for joining us today.
Thank you so very much for having me here. It's a pleasure to be here, and thank you so much for everyone for joining as well.
Thank you. The floor is all yours.
Thank you. So I'll share my slides. So again, thank you so much, everyone, for joining. It's a pleasure to be here. I've been, I believe this is my third or fourth time doing this, and every single time it's been a fantastic experience, and I welcome any questions, comments. I know we're keeping those to the end of the program, but I do welcome any input you may have. And so it's a pleasure to be here to speak on lung cancer. My focus is thoracic oncology. And so as Larissa was mentioning, I've been part of the program here for the past 9 years. And I've been taking part in the clinical trials that we have for lung cancer, especially with immunotherapy. And so it's been a pleasure to be part of this journey for the past 9 years, seeing how much the treatment for lung cancer has progressed and how many new therapeutic options are available to patients with lung cancer. So the field is growing by leaps and bounds almost on a yearly basis, which has been phenomenal. So without further ado, I'll just jump right in. So just a few housekeeping notes. The following slides were medically reviewed by Dr. David Carbone in April of this year. And this program was developed by Cancer Support Community. It was developed independently, and then outside medical and psychosocial experts reviewed it. The Cancer Support Community has final control over the content of the program, and it was generously sponsored by Amgen and Bristol Myers Squibb. And I was invited to engage in this program. I have my disclosures are noted there. I have no financial relationships or affiliations other than what's noted there. All right, just in terms of the overview, so just brief introductions, and then we'll be talking about what lung cancer is, the importance of partnering with an important healthcare team and being comfortable with the healthcare team. We'll discuss that briefly. Also, understanding treatment options for both non-small cell lung cancer as well as small cell lung cancer. We'll talk about managing side effects as well as living with lung cancer, and then we'll come to questions and answers at the end. So tips for living in this strange new land when someone is diagnosed with cancer. You or your loved one may have been diagnosed with cancer, but that doesn't mean that cancer has you. What's most important is when someone receives a diagnosis of cancer is to first and foremost receive as much education and information about the diagnosis as possible, especially when it comes to lung cancer. It's very important to build a support team around you when you have a diagnosis of lung cancer. And most importantly, especially in this day and age with so many new treatment options available, having hope and courage when in the setting of being faced with a diagnosis of lung cancer. So what is lung cancer? Lung cancer is the second most common cancer in both men and women. It is the deadliest cancer in both men and women, even though it's the second most common. And there are two main types of lung cancer. There's non-small cell lung cancer, and then there is small cell lung cancer. And so that's one big differentiation that we need to make. And I let all my patients know whenever the first time we sit down together that there's two main categories. There's small cell, which we'll talk about, which tends to be a bit more aggressive, more common in patients who have had a heavy smoking history. And then there's non-small cell, which essentially just means not small cell, but the two categories are very different. And it's important to differentiate them because the treatments we recommend are different for small cell versus non-small cell. Now, in terms of taking one step back, there is a movement in terms of lung cancer screening. And so before someone is diagnosed with lung cancer, one part of trying to catch lung cancer early is trying to build up these lung cancer screening programs. This is where a lot of primary care physicians come into play, where if someone has a significant smoking history or they're current smokers, they would be eligible to undergo lung cancer screening, which is with a CT scan. So the reason why we do this, there was a study done a number of years ago that actually showed that doing these lung cancer screening with low dose CT scans actually helps to detect lung cancer early and actually reduces the risk of death from lung cancer. So there's about a 20% reduction in death when lung cancers are caught early. So there is a benefit of doing these lung cancer screening CT scans. So it does help to detect lung cancer early, and it is a low dose chest CT scan. So those who are eligible to undergo lung cancer screening are those between the ages of 55 to 80 who are current smokers or previously smoked but quit within the past 15 years. And at minimum, they should have a 30 pack year smoking history. And we usually calculate pack years as the amount smoked times the number of the years smoked. So if it's one pack a day for 30 years, that's 30 pack years. If it's 2 packs a day for 15 years, that's 30 pack years. So in terms of non-small cell lung cancer, so we mentioned that there's a differentiation between non-small cell as well as small cell. So in terms of non-small cell lung cancer, non-small cell lung cancer itself has further differentiation. So within non-small cell, which is the most common type of lung cancer we see, that makes up about 80 to 85% of all lung cancers we see, especially in Los Angeles and within California. Adenocarcinoma is actually the most common subtype. So adenocarcinoma is a type of non-small cell lung cancer. Another type is squamous cell lung cancer, which is noted here. That's the second most common type. And then yet a third type is large cell carcinoma, and that's less than 10% of patients with non-small cell lung cancer. The difference between what's listed here on the slide, adenocarcinoma versus squamous versus large cell, is really which cell within the lungs decided to just flip a switch and become a cancer cell. By far, the most common type is adenocarcinoma, but we do see squamous and large cell as well. So these are just different types of non-small cell lung cancer. And again, this also is important for oncologists to know what kind of non-small cell it is, because the treatments we recommend also depend on the type of non-small cell lung cancer. So all this information is important to have ready at hand when making a determination regarding treatment options and the best treatment options for patients. In terms of small cell lung cancer, which we mentioned is different than non-small cell lung cancer, small cell lung cancer makes up about 15% of lung cancers in the United States. So it is more common in heavy smokers. And nowadays, thankfully, we are seeing less significant heavy smoking history. And so we're not seeing small cell as much, even though we do see them occasionally. Small cell tends to be more aggressive. It does grow more rapidly and metastasize more readily than non-small cell lung cancer. And again, about 98% of cases are attributed to smoking. So partnering with a good healthcare team is one of the most important steps when someone is diagnosed with lung cancer. your healthcare team should provide excellent care. And that includes a medical oncologist. And at best, it's good to see a medical oncologist when someone is diagnosed with lung cancer, someone who actually specializes in thoracic oncology, or has significant familiarity with thoracic and lung oncology. If you need to see a surgeon, one who is board certified in thoracic surgery is also important. And thankfully, we have a number of good thoracic surgeons in Los Angeles. Radiation oncologists may be part of the healthcare team when someone is diagnosed with lung cancer. And also there are other members of the multidisciplinary team, especially nowadays when there are so many members in someone's healthcare team. That includes nurses, other doctors, social workers, case managers, physical therapists, nutritionists. So nowadays we do have a more comprehensive approach that we're using to patients. In our clinic, for example, we have a nutritionist, we have a supportive care physician, we have a special physician now who is more towards physical, if someone needs physical therapy or other support systems in order to get their energy and activity levels improved. And so we are taking a more comprehensive view and approach in terms of patient care. It's not just the oncologist and the patient, it's more really a multidisciplinary approach. Communication style is very important. So being able to communicate with your team, with your healthcare team is very, very important. Hearing what the patient has to say is the most important part of this process. So making sure that the needs are listened to, the symptoms are listened to, it has to be done with respect, and also making sure all questions are answered. And so this can be a very confusing time when someone is diagnosed with lung cancer. And so making sure that all this information, as in the what is non-small cell lung cancer, what's adenocarcinoma, what's the diagnosis, what does the biopsy show, what does the surgery show. So all of that is very important to really understand when someone is newly diagnosed with lung cancer. So having a clear, direct, and open communication with the healthcare team, with the oncologist, with the surgeon, with the radiation oncologist is very, very important. In terms of second opinions, there's a very nice quote here that says, if I learned one thing, is that when dealing with any chronic disease, you have to be your own best advocate. There were several times that we brought a second opinion to the table. We felt it was better to be armed with information and come with an opinion versus just sitting back and letting someone else make all the decisions. I can't highlight this enough. And in fact, whenever I meet a patient for the first time, and if I'm the only voice that they have heard, I usually tell them that they absolutely need to be comfortable with the treatment plan that is being outlined for them. And so I actually encourage patients to go get another opinion. And the other opinion may completely agree with the first opinion, which may be my opinion. I also have patients coming to me with a second opinion for a second opinion, or sometimes even a third opinion. And for the most part, we do have the treatment for lung cancer is for the most part very standard therapy. And so most people do end up agreeing with the treatment decisions that are outlined, but it's always nice to hear that someone else agrees with the treatment decision, because it's very important then when someone is diagnosed with lung cancer, they're very comfortable with what they're hearing and the treatment that is outlined when it comes to their for their the treatment of their lung cancer, whether that's chemotherapy, radiation, immunotherapy, surgery, all of that, those factors are taken into consideration. And so in terms of communicating with your healthcare team, bringing questions to appointments is important. A lot of times, as in my patients, they have questions written down beforehand so that they're not trying to remember during the appointment, because sometimes it's easy to forget questions that you may have had. So just writing it down and bringing the questions to the appointment is helpful. And then writing things down during the appointment, because a lot of times, and doctors know this as well, that sometimes a lot of what we say may be forgotten. And I think the general quote is that especially during a first consultation, only about 20 to 30% of what we say is actually remembered. So writing things down, and I typically tend to write down things for my patients, but also for patients to write things down is helpful. Of course, bringing a friend or a family member to take down notes and also to listen and to be a second ear in terms of getting all the information is helpful. asking for copies of test results, asking about side effects or symptoms, and then also just making sure that to relay all the medicines, including vitamins and herbs and supplements, to the healthcare team and to doctors so that doctors are aware as to all the medications, including herbal and supplements and vitamins that an individual takes. Understanding treatment options is important. Now, our treatment options are becoming very complicated. So about 15 years ago, it was very standard treatment that everyone received. It was almost one size fits all, but now we know that that is absolutely not the case. The treatment of lung cancer has actually become very, very complex. And sometimes it does take a couple of conversations to really understand what the treatment entails and what the side effects are. And so understanding those treatment options is important. Treatment options do vary and they do depend on staging and the type of cancer. So staging, which we're going to discuss shortly, depends on how extensive the cancer is. The type of cancer makes a difference. So whether it's small cell versus non-small cell, within non-small cell, is it adenocarcinoma or is it squamous cell? So it all makes a difference in terms of treatment. General health at the time of diagnosis, is someone well enough to tolerate chemotherapy? So that's important. Health history, are there any other medical conditions or comorbidities that will make treatment challenging? And then goals of treatment, is our goal to cure the patient of their lung cancer, or is it palliation, just essentially relieving symptoms and then prolonging, just making sure that we're treating it more as a chronic condition, and just continuing treatment. Discussion of treatment options with experts in lung cancer. And so that includes thoracic surgeons, medical oncologists, and radiation oncologists. So the treatment options, especially when there are multiple physicians involved, like surgeons and radiation oncologists, the treatment options do encompass discussions with all three. So thoracic surgeons, medical oncologists, as well as radiation oncologists. And some questions to discuss with your doctor include questions such as, which treatment do you recommend and why? Most doctors will discuss this automatically, but it's also important, if you don't hear the answer to that question, it's important to ask why. Why are you recommending this treatment? What short and long-term side effects might I expect? And so this is a very important question, as most patients are worried about quality of life, especially with chemotherapy, when we discuss chemotherapy with patients. How will I know if the treatment is working? Are clinical trials an option? What can I do to prepare for my treatment? Who do I contact if I have questions? So, and that's very important. So if someone goes home and they have questions, how are they able to get in touch with the doctor? Who are they supposed to connect with? So a patient should never feel like they're in a silo alone. They should always be able to communicate with their doctor's office. They should always have access to their doctor. So whether that's via phone call to the clinic or communication via portal, they should always have access to their physician. What support services are available to me and my family, and how do I get help with managing the cost of my cancer care? So those are all very good questions to bring up to the doctor, to the oncologist, during their appointments. So in terms of treatment options for non-small cell lung cancer, now thankfully this is an area where, again, drug development and progress has been made by leaps and bounds over the past 10 years. So staging is very important. So we have, usually we have 4 stages. So stage 1, 2, 3, and 4, as we see here. Stage 0 means that it's really not invasive. Stage 0 is very, very early stage. It's typically rare for us to catch lung cancer at stage 0. Usually we're catching it at later stages, either stage 3 or 4. Stage 1, we can sometimes see if someone has had lung cancer screening, CT scan, or if incidentally they went in for something else and had a chest X-ray or CT scan, and then all of a sudden we see a lesion in the lung. So the reason why lung cancer is caught later on in stage is because most patients don't have symptoms when they have stage 1 or 2 disease. The difference between the staging is that stage 1 indicates early stage, so meaning that there's something small in the lung and it's only in the lung. That's usually stage 1, 1A or 1B. And so with stage 1, if there's something small in the lung, most patients are not really complaining of a cough in that scenario or shortness of breath. Stage 2 means that there's still something in the lung. It's a little bit bigger than stage 1. And at this point, maybe there's also a lymph node involvement in the middle of the chest. Lymph nodes are these, it's almost kind of like a bunch of grapes that are in the middle of the lung. And it's the first place that lung cancer likes to travel to when it becomes, when it starts growing and starting to spread. And so the first place that it goes to is the lymph node. So stage 2 means that the mass is a little bit bigger, and maybe we're seeing a lymph node involvement in the middle of the chest. Stage 3 means that the mass is bigger, and now we have more lymph node involvements. Now stage 3A, 3B, and 3C are treated differently. There's 3A, and then there's 3B and 3C. And so basically that designation just means mass in the lung and then more lymph node involvement in the middle of the chest. Stage 4 is when the lung cancer cells have started to travel outside of the lung. And that's what we mean by metastatic lung cancer. So we know that there's cancer in the lung, but now it has started to travel, whether it's to the bone, to the adrenal gland, to the liver, to the brain. These are some of the places that lung cancer likes to travel to. So stage 4 just means it's traveled outside of the lung. Now, because most patients don't really have symptoms, when they have stage 1 or 2 disease, most of the time when we have diagnosis of lung cancer, we do catch them at either stage 3 or 4. It's not to say that we don't see stage 1 and 2, we do, but majority of patients are diagnosed as stage 3 or 4 because they don't really have symptoms until they have stage 3 or 4 disease. So treatment options for non-small cell lung cancer include surgery. So the earlier the stage, the greater the chance that a patient is going to be eligible for surgery. So we usually offer surgery if someone is diagnosed with stage 1, 2, and sometimes with 3A disease. So those are usually the stages where we can engage a thoracic surgeon so that surgery is considered an option. Radiation therapy is usually considered for stage 3 and 4 disease, and systemic chemotherapy can be incorporated at any time. And so systemic therapy includes chemotherapy, targeted therapy, which we'll talk about, and then nowadays also immunotherapy. And chemotherapy and immunotherapy are different, which I'm going to get to in a second. But these are types of systemic therapy. So meaning by systemic therapy, meaning therapy that someone takes, whether IV in terms of chemotherapy and immunotherapy, or targeted therapy, which is a pill, but the goal is for the drug effect to go everywhere in the body to kill off any small cancer cells that may be hiding. Now, in terms of surgery, if your cancer has not spread to other tissues, your doctor may recommend surgery to remove the tumor as a first option. So again, this goes to when someone is diagnosed with stage 1, 2, and sometimes 3A disease. And there are different surgical options. And so those include wedge or segmental resection, meaning just going in and cutting off part of the lung. Lobectomy involves removing one lobe of the lung. Pneumonectomy involves removing an entire lung. So that would be basically removing the entire right lung, the lobes of the right lung, or removing the 2 lobes of the left lung. So that's pneumonectomy. In terms of radiation therapy, so radiation therapy uses high energy rays to kill cancer cells. So the way it works is it basically damages the genetic material in the cells. It's basically just going directly to the cancer cells and trying to kill off the cancer cells. And for some people with cancer, radiation therapy is the only treatment that is needed. And for others, radiation is given either before, during, or after chemotherapy, targeted therapy, or surgery. So radiation can really be incorporated anytime. And it really depends on case by case and individual by individual as to where the disease is and what stage the patient is diagnosed with. In terms of chemotherapy, we do have a number of chemotherapy options. And so the names are listed there. And so I'm not going to fixate on all of them, but the most common ones that people are going to be familiar with is going to be cisplatin or carboplatin and pemetrexed or Alimta. And these are typical common agents that we use in terms of treatment for non-small cell lung cancer, especially for adenocarcinoma, which is what we see more commonly. But these are some of the options in terms of chemotherapy drugs that we have that we typically can use in our in our toolbox and for to treat patients. Biomarker testing. Now, if there's one thing that I want folks to get out of this program is that it is so important to talk with your doctors to get biomarker testing. This is one thing that has just been recently become more pronounced over the past 5 years, only because targeted therapies have just had such development over the past couple of years. So up until 5 years ago, if someone was diagnosed with lung cancer, they would get an EGFR or ALK testing, and that was it. But nowadays, we have so many more targeted therapies. And by targeted therapy, I mean that when someone is diagnosed with lung cancer, the pathologist can do specific tests to check for a protein. And some of those proteins are listed here: EGFR, ALK, ROS1, BRAF. These are names, but basically what they do is these are proteins that sit on the tumor cells, and they're sending signals to the cancer cells to allow the cancer cells to grow. We've identified these proteins, and now we have drugs that target these proteins. If we identify if someone has one of these markers, then we have a pill that can target those proteins and essentially shut off that signal that the protein is sending to the cancer cell to continue to divide, meaning that the targeted therapy can target the protein, shut off that signal so that the cancer cell dies. We will not know if someone has a protein to target unless the oncologist actually does the testing. So in my practice, when someone is newly diagnosed with lung cancer, whether I'm catching that on a biopsy or if someone has had surgery and they're coming to me after surgery, I always check for all broad molecular testing / mutation testing. We usually use those words interchangeably. So I really need to know whether someone has EGFR, ALK, ROS1, BRAF, NTRK, MET, RET. The reason being that if someone has one of these mutations, depending on their stage, then I know that they may not need, or they may need chemo, but then I have another therapy for them afterwards. So it's very individualized therapy. So it's very, very, very important that patients undergo mutation molecular testing, either at the time of biopsy or or after surgery. Testing for PD-L1. Now, nowadays, when we're all using immunotherapy, we always want to know how can we check to see if someone's going to be responsive to immunotherapy. PD-L1, which is also a protein that we check for on the tumor cell, that's basically the only best marker that we have right now. It's not the only one, but it's the best one. It's also not the best marker, but by far of all the markers available, it is the best one. So we do routinely check for those as well. So again, who should get tested? Really all patients who are diagnosed with lung cancer, non-small cell lung cancer, should get tested for all of these PD-L1 and mutation testing. Small cell lung cancer, they can also undergo this testing, but the information there is not going to be as helpful as non-small cell lung cancer. So very, very important that patients undergo all this testing. And when should the testing be done? For me personally, I get it done at baseline when someone is diagnosed or after surgery. Testing can also be done if someone is on treatment, they have stage 4 disease, they have treatment, and then the cancer starts changing and it starts growing and dividing. And so at that point, it's also good to repeat molecular testing just to check and make sure that all options are considered in terms of treatment options. Where is testing done? Testing is usually done on tissue biopsy. So it's done either via, if someone has had a biopsy at the time of diagnosis, or a surgical biopsy or surgery, we get the tissue, and usually the oncologist sends it out to an outside facility where the testing is done. Nowadays, there is something called a liquid biopsy, which is just basically a blood test that we can collect in the office, and we send it out to an outside agency where they can then do testing and check for mutations. Liquid biopsies can actually miss some mutations, they can miss up to 30% of biomarkers. So if someone does a liquid biopsy or a blood test, it's always, and the results are not too helpful, it's always good to do tissue biopsy as well. So again, biomarker testing is very important because you really need to have all the information available and to know and make a good decision regarding treatment options. In terms of targeted therapies, we already discussed this. So these include the proteins that need to be tested, so the mutations or molecular markers that need to be tested. And this highlights the number of treatments that are available. Now, these, for the most part, are pills that patients can take. And so if someone is diagnosed with stage 4 disease and they have an ALK rearrangement, then we have all these drug options that are available in terms of a pill option. So instead of starting with chemotherapy, someone can start off with a pill. Same with EGFR. If someone that is diagnosed with an EGFR mutation with stage 4 disease, then we have these drug options in terms of starting with targeted therapy and not necessarily jumping to chemotherapy. So that's why identifying one of these markers is so important at the time of diagnosis. Now, in terms of immunotherapy, immunotherapy has become part of the conversation over the past couple of years, especially over the past 5 years when various immunotherapy drugs have become FDA approved. The goal of immunotherapy is basically to use the body's own immune system. We all have an immune system in order to help get rid of things that don't belong in the body. And so cancer cells are very intelligent, though. They have figured out ways to outsmart the immune system so that the immune system doesn't recognize them, and then they can grow in the body. And so the goal of immunotherapy is basically to stop the cancer cells from fooling the immune system so that the immune system is alerted and woken up and stimulated so that the body's own immune cells go and attack the cancer cell. So this is an area where also there's been significant drug development. We have a number of immunotherapy drugs that are FDA approved. That includes atezolizumab, also called Tecentriq, durvalumab, also called Imfinzi. Durvalumab we use mostly for stage 3B or 3C disease after someone has had chemotherapy radiation, and then they receive a year of durvalumab. Nivolumab, which has been around for a long time now. Usually that's given for stage 4 diagnosis. And nowadays there's also an approval of using nivolumab in combination with another immunotherapy agent for stage 4 disease. Keytruda, pembrolizumab, has been around for a while. That's also given for stage 4 disease. And cemiplimab, which was more recently approved by the FDA, also approved for stage 4 disease. Shifting gears a little bit, so talking about small cell lung cancer, and we'll talk about treatment options for small cell. Now, when someone is diagnosed with small cell, there's two different staging that we do. We talked about non-small cell staging, how there's stage 1, 2, 3, 4. For small cell, we usually classify it as limited stage, meaning that the cancer is limited to one lung and it's only in the lung, it's not anywhere else, versus extensive stage. Extensive stage just means that it's spread outside of the lung. It does make a difference in terms of staging, whether it's limited, very limited to the lung, or outside, because if it's limited, then we're going to use chemotherapy and radiation together, versus if it's extensive stage, then the treatment is usually nowadays it's with chemotherapy and immunotherapy combination. In terms of treatment options, surgery is limited in its use. So we offer surgery only if it's very, very, very small lesion or spot in the lung. Usually surgery is not part of the treatment regimen for small cell, given that it tends to be aggressive and patients need to start on treatment ASAP. But in some rare instances, surgery can be incorporated into the patient's regimen. There are some standard chemotherapy drugs as listed here. The most common first-line treatment options are cisplatin or carboplatin with etoposide. So cisplatin and etoposide, or carboplatin and etoposide, are the most common chemotherapy drugs. And nowadays we are coupling that with immunotherapy, and the two immunotherapy agents that are approved are atezolizumab or durvalumab. So that tends to be the frontline therapy for extensive stage disease. For limited stage disease, the treatment is still cisplatin and etoposide along with radiation. And that's where radiation comes into play, as listed here, is for early stage disease. For extensive stage disease, sometimes we do use radiation if someone's having symptoms somewhere. And then laser therapy can sometimes be used to kill cancer cells blocking an airway, because small cell lung cancer tends to grow more centrally in the chest, and it can sometimes block airways and blood vessels. And so sometimes we need to use laser therapy to offload the pressure that the cancer is causing. Immunotherapy, I mentioned, can be part of small cell. Now, immunotherapy, Keytruda specifically, or pembrolizumab, is also approved apart from just the treatment of non-small cell lung cancer. In the small cell lung cancer arena, if someone has specific characteristics of their small cell, meaning things that we classify as microsatellite instability or tumor mutation burden, these are things that the oncologist is going to check for. So if they have these things that are found on their biopsy or their surgical tissue, then they would also be eligible to receive immunotherapy. Targeted therapies are not ready for prime time yet in small cell, but there's a lot of clinical development and clinical trials that are looking into that option for small cell. So speaking of clinical trials, so clinical trials basically are trials, especially nowadays, where they're promising new treatments. Every lung cancer treatment regimen that is available now and was considered standard was actually developed through a clinical trial. So tomorrow's standard treatments are actually today's clinical trials, and participants are not considered guinea pigs. They all receive either the standard of care or the new treatment with known benefits and risks. So clinical trials are very, very important. Our clinic was actually part of the phase one, when Keytruda first became available in a clinical trial format. And so we've been part of seeing how Keytruda has become such a norm and how often it's been used now. When we were at the inception, when the drug was first introduced into the clinic via clinical trials. So clinical trials are very, very important in terms of treatment options for patients. A clinical trial may be the only way to get certain treatments, including some that are very promising. Every trial is under the review board and is overseen by the FDA. So every small thing that is done in a clinical trial is overseen by the FDA and is reported to the FDA. And every doctor does not have the same trial. So one unfortunate thing is that actually, well, it could be unfortunate and good thing, is that every single institution has a different clinical trials. But what makes it challenging is that a patient is not going to know what trial is at what institution. They physically have to make a phone call or look into the options of different trials at different institutions. Trials are available for different stages and types of lung cancer, although everyone is not eligible for every trial. And if you join a clinical trial, you can leave at any time. So a patient does have the autonomy to join and leave a clinical trial. The power is with the patient to make that decision to join and then leave if they don't like how they're feeling or they just don't want to continue participating in the trial. And most often, the trial pays the cost of the drug being studied, and the health insurance helps pay for the standard treatment costs. So, but in terms of financial coverage, that's also a conversation that needs to be had in terms of when someone is enrolled in a clinical trial. For the most part, the insurance or the company that's sponsoring the study helps cover the cost of the clinical trial. In terms of side effects, which is very important, so some common side effects of treatment. Now, not everyone is going to have the same side effects, but some side effects that we list that are possible include fatigue, trouble breathing, pain, nausea, vomiting, diarrhea, constipation. Diarrhea is very important, especially if someone is on immunotherapy. Loss of appetite, which we can sometimes see with chemotherapy, mouth sores with chemotherapy, peripheral neuropathy is possible, low blood counts, infection, hair loss. Thankfully, a lot of the treatments that we have for lung cancer nowadays don't cause hair loss, but some like docetaxel do, but it is still a possibility. Skin changes, sexual reproductive changes, as well as anxiety and depression. In terms of coping with side effects, the most important thing is to report any and all side effects or symptoms to your healthcare team. So it's important that the healthcare team is aware of if you're having any side effects so that they can address it ASAP. And common side effects such as fatigue, pain, and breathing problems are all treatable and manageable. Stress and the emotional impact of cancer can be significant and can be managed. Palliative care is something that is now being offered more widely. Now, palliative care is not hospice. In our clinic, we typically use our physicians, or we call them as supportive care, because they're there. So we have specific supportive care physicians who address the patient's needs as symptoms or side effects come up with treatment. So that could be if they have loss of appetite, our supportive care physicians come in and help the patients work through their loss of appetite, whether it's through encouragement or medications. Our nutritionists are there to help them through that. Fatigue, so supportive care can address fatigue. They can address pain management. So these are all things that can occur through as someone is receiving therapy. So it's not to say that palliative care is hospice. It's a group of physicians and healthcare professionals who are there to really support the patient as they're going through their treatments to make sure that their side effects are being tended to. No one should suffer through treatment. They should have their side effects addressed appropriately with their team of medical providers. So that's where palliative care and supportive care physicians come in, and they're not only physicians. This include nurse practitioners and physicians assistants and nurses who can help and guide the patients through their symptoms and side effects as they're going through treatment. Now, living with lung cancer, the good news is that with our treatment options, patients are living longer with lung cancer. I have patients now going on 8 and 9 years after diagnosis of stage 4 lung cancer. So patients are living longer with lung cancer because, again, our treatments have become much better. And so, but there's a couple of things that can factor in when someone is diagnosed with lung cancer. So especially when they have a new diagnosis, there could be loss of hope, loss of control, living with uncertainty. Even going on many years, someone can have uncertainty, especially when scans are coming up. When someone is diagnosed with lung cancer and they go through treatment, they need to have CT scans every once in a while. There's always that uncertainty as to what the CT scan is going to show. Aloneness with a diagnosis that can come with a diagnosis of cancer. So some of the challenges of living with lung cancer include additional challenges because of how the cancer is thought by you or others. There may be feelings of guilt, anger, and even blame when there's a lung cancer diagnosis. Hopefully this is getting less and less though. The burden of these emotions can get in the way of recovery, and everyone diagnosed regardless of smoking status is entitled to compassion and the best available treatment. So it doesn't matter how someone got cancer, it doesn't matter what stage of cancer there is, everyone is entitled to respect, compassion, and absolutely the best treatment available out there. That just is a necessity. The stress can be part of it, and it can impact cognitive, behavioral, and social, emotional, and spiritual functioning. It's very important to talk to your doctor when the stress is noted. And symptoms of depression and anxiety can be depressed or irritable mood, lack of pleasure in activities, appetite changes, sleep disturbances, fatigue, difficulty concentrating, restlessness, suicidal thoughts. Paying attention to these symptoms and making the physician and the healthcare team aware is very important. We also have psychosocial services here. We have a social worker who also has the capacity to be a therapist. We also have a psychiatrist in our staff so that all of these members of the team can come together and really help work with the patient to work through any distress or anxiety or depression that they may be feeling as they're going through their journey. Also understanding that there's positive attitude, optimism, and hope. Being positive, optimistic, or hopeful does not mean that you do not feel negative emotions. It helps to develop realistic expectations about your illness, that you can focus on making decisions about your care and your life. People who find hope and reasons to be optimistic can have better quality of life. I can't stress this enough. Sometimes, of course, it's easier said than done, but it is those who are optimistic and who have a positive outlook do overall tend to do better. They have less side effects. Those who are engaged in their community and have a support system, they just tend to do better and navigate the process better. And also just the benefit of emotional expression, just expressing how you feel and how things are going during treatment. So this can lead to improved physical and mental health, greater ability to be in control of one's emotions, having more self-confidence and assertion, expression of support, empathy, interest, and humor. So those are all very important as someone is navigating this process and this journey through treatment. Repressing emotions, of course, can lead to aggressiveness and hostility, just irresponsible, inconsiderate impulses, and alienation and isolation. So negative emotions that we want to not to have someone go through. We want to have them be as positive as possible as they're going through their treatment. Reaching out for help is very important. So every person needs to find his or her own way of dealing with the situation and coping with the diagnosis. And there may be many ways of finding help. And this can be either talking openly with trusted friends, family, finding a support group, which is something that the cancer support system does so well, using an online resource, talking with clergy or trained mental health professionals, keeping a journal, singing in a choir, and then just trying any mind body programs for stress relief can be very, very helpful. And other ways to take care of yourself. So nutrition, eating well, exercising is so critical and so important. Sleeping well is important. Social support, hobbies, pampering yourself, spiritual practice, connecting with others, and then just processing emotions as we just talked about. Another quote here, I'd say as a person who was raised to be independent that I wasn't accustomed to leaning on anyone. With cancer, you have to let go. You have to rely on the strength and love of other people. I think this is such a great quote because I think this also highlights one of the real challenges that patients face when they go through cancer. Because inevitably, when someone is on treatment, they're going to most likely have some type of either side effect or something that they may be going through. If they're not even having a side effect, it may be the emotional component. And so something where they need to rely on someone else. And a lot of patients have difficulty doing that. But it is once they realize that it's okay to let someone else take care of them, then the process becomes easier. And what I find is that most family members or most friends are willing to be there for patients and to really help them along. And tips for caregivers. So for as a caregiver, it's also important for caregivers to remember to take care of themselves. Also important for them to talk to others for support. There are some online tools that are available to care providers and caregivers. So mylifeline.org, which can help with scheduling needs and accessing support from family and friends, communicating with loved ones and loved ones healthcare team is also very important. Again, just having a very open and direct communication with a physician, the oncologist, and just the entire healthcare team is so important. Also, just having legal tools that are important. This is important for everyone, regardless of either diagnosis or not. Just having a living will, healthcare proxy or medical power of attorney, financial power of attorney, and a will. So just having things arranged just gives someone a peace of mind. And again, this is important for just everyone. And then there are resources available. There is a cancer support helpline, and the number is available there. And open to options. The Frankly Speaking About Cancer programs such as these, in order to just have the tools and the information and the education about these resources that are so important. There's also a cancer experience registry that is specific for lung cancer, and it's a research survey to identify and understand emotional and social needs unique to lung cancer experience. It informs medical professionals about patient needs to improve quality of care, and is confidential and secure. It's beneficial to participate if someone is willing to help the cancer support community, qualified healthcare providers, and researchers to understand the issues that are important to lung cancer community. And it can transform lung cancer care. And the intention is to deliver improved services to those affected by lung cancer. And this is the website in order to join the registry. And there are a few steps involved that we're happy to provide the information to you if you're interested. And then there are ways to join the cancer support community's grassroots movement in terms of ensuring that people touched by cancer have access to quality and comprehensive cancer care, which also includes social and emotional support. So all that information and all of these information is also available to you guys. And this is another website where there's additional information in terms of resources that are available to you. And here's additional resources. And so with that, that brings me to the end of our program, and I'm happy to take any questions that may have come up.
Thank you so much, Dr. Balmanoukian. That was such wonderful information. If you don't mind ending your screen share there so we can see you.
Yeah.
Okay. All right. I also put in the chat if you have any further questions, if you would also like to see those resources again or have access to them, please email info@cancersupportla.org. One question that I see we got, I think twice here, is what's the difference between 1A and 1B?
So the diagnosis, the difference between the staging can certainly be confusing. So given that there's 1A, 1B, 2A, 2B, the difference is that we have a certain set of guidelines in terms of what we classify as staging. So 1A, 1B versus 2A, 2B. It really depends on the size of the mass. So if someone is diagnosed with lung cancer and they have one spot in their lung, so the difference between is if it's 1 centimeter versus 2 centimeters. So that difference can that's where the designation between 1A versus 1B lies. It's basically the size of the lesion. So even though it says 1A or 1B, that patient is still classified as stage 1 disease.
Okay, our next question is, can someone outlive a lung cancer diagnosis?
Absolutely. I have a number of patients in my practice who, they have at this point, they have a history of lung cancer. So essentially, if someone is diagnosed with stage 1, 2, or 3A disease, where our goal of treatment is for a cure, that patient will need 5 years of surveillance, meaning CT scans every 3 months for the first 2 years, then every 6 months for year 3 and 4, and then one CT scan year 5. Beyond 5 years, that patient is considered cured of their lung cancer. Stage 4 is the only the stage where the patient needs to continue with therapy. So stage 4 is when we classify the patient as having a chronic disease. But for stage 1, 2, and 3A, the patient certainly has a chance of outliving lung cancer.
Okay, we have someone asking, I think about maintenance. They said they've had surgery, ablation, and radiation. They're now scanned every 3 months, and they believe that that's what they're going to be doing for the rest of their lives. So they're wondering if there's more that they might be able to do to stay as healthy as possible.
So they've already had surgery, ablation, and radiation, and their treatment is done. So if they're going through just monitoring and scanning every 3 months, then the best thing that they can do really is just to maintain a healthy of a lifestyle as possible. So just being active, exercising, eating well. If they're not on treatment right now and they're only on surveillance, then just keeping a healthy lifestyle is the best way. There's really no great nutritional supplements or vitamins or herbal supplements that we're aware of that can really impact in terms of how someone does in the surveillance period. So really just a good lifestyle, healthy lifestyle is important.
All right, great, thank you. All right, we have a couple more questions. The next person is asking, they were just recently diagnosed with airways disease, and they're wondering how that relates to them also having lung cancer and the treatment.
So airway disease is unfortunately a broad diagnosis because it doesn't necessarily relate to cancer. Airway disease can also just be a benign process that the pulmonologist diagnoses. So airway disease can mean emphysema, it can mean interstitial lung disease. So It depends on what they're categorizing as airway disease. Now, if someone has a history of smoking and they're diagnosed with COPD or emphysema, then that patient needs to be undergoing screening, lung cancer screening, CT scans if they have a history of smoking, because there is a chance possibly of cancer. Not to say for obviously nothing is certain, but if there is a smoking history, then undergoing lung cancer screening CT scans would be beneficial. But independently, just airway disease doesn't necessarily confer that there is an underlying malignancy.
Great. Thank you for that answer. Okay. Someone's asking, what do you tell patients diagnosed with stage 4 in terms of prognosis?
Um, in my practice, I usually just like to be as optimistic as possible. And so, yeah, with stage 4 disease, we know that the cancer has traveled outside of the lungs and that we're not going to be able to cure it. But with everything that we have right now, with the drugs that we have and the clinical trials that are in development, patients are living a lot longer than they have before. And so, what that time frame is very different for everyone, but certainly patients can live a very long time with a stage 4 diagnosis. So I tend to be as optimistic as possible in terms of prognosis. I never give numbers because doctors are the worst at giving numbers. And so we can't cure stage 4 cancer, but someone can certainly live with stage 4 lung cancer.
All right. Thank you. Okay. And I assumed we would get a COVID question, and we have. They're asking, they said they have radiation pneumonitis. I hope I'm saying that right. After radiation therapy for lung cancer, and they're worried about getting COVID. So they want to know if we know anything about COVID and lung cancer, and if it's survivable.
That's a great question. It's been in discussions quite a bit just in the past 2 years. And so it is possible to get COVID, have lung cancer, and get COVID. We do ask our patients to be as careful as possible. And most of our patients are, most of them have received the vaccine and now the boosters. If someone has had pneumonitis, that means that their lung reserve is less than if they haven't had pneumonitis. And so if they have COVID and it does go down to their lungs, they're just going to have a harder time recovering from COVID. And so we do ask that patients be as careful as possible in terms of social distancing and masking. And thankfully, it also looks like there's new therapy on the horizon to treat COVID, so that hopefully it's not going to be as dangerous. But I've certainly had patients who've had COVID with cancer who have also, gone over it. So.
Great, thank you. Glad to hear that there's some things being studied on the back end there.
Mm-hmm.
Yeah, which leads to our last and final question. If someone's asking, is there any hope for a future cure, or what is being worked on right now?
Yeah, absolutely. Again, as optimists, as oncologists, we always wear an optimistic hat. And so especially someone who is in, I'm in drug development, I do clinical trials here. We're always optimistic that there's always going to be another, impressive immunotherapy drug out there. So there is a lot of focus on immunotherapy development. And so just utilizing the immune system in terms of fighting cancer cells, because it's such a natural process of what typically happens and what we want to happen. And so there's a lot of development in terms of clinical trials on immunotherapy. That can be a little challenging because we know that immunotherapy doesn't work too well in terms of targeted. So if someone has mutation, but those are things that are being evaluated, and there may be immunotherapy drugs out there that may work in EGFR mutated lung or ALK rearranged tumors. So that waits to be seen, but there's a lot of drug development in that area. So immunotherapy is big, vaccine development is being looked at, and then just a lot of development in targeted therapies as well. And so we're looking and we're seeing that there's a lot of new drugs on the horizon in terms of EGFR, ALK, ROS1, so all of that is also pending. So we're optimistic that we can talk about a cure at some point. So I continue to be very hopeful.
Great. Thank you for keeping the optimism alive. We'd love to hear that. Spread the hope. And thank you so much for your time with us today, Dr. Balmanoukian. This was such wonderful information. If you have any other questions, please feel free to email info@cancersupportla.org. And thank you again, Dr. Balmanoukian. It was such a pleasure.
Thank you so much. I appreciate it. And thank you, everyone.